Welcome to Stroke News. This is episode 4. In many recent stroke and vascular conferences, one of the main debate topics is carotid endarterectomy versus carotid artery stenting, as if it is a war and one side has to win. Two experts are placed on opposite sides. One argues passionately that endarterectomy is the gold standard and stenting is dangerous. The other argues with equal conviction that stenting is the future and open surgery is obsolete. Statistics are deployed like weapons. Pooled analyses are dissected line by line. Subgroup data is selectively quoted. And at the end of it all, the audience, perhaps more confused than when they walked in, with no clear practical message to take back to their patients. I have sat in that audience many times, and every time I have thought the same thing. Are we asking the wrong question? Because the real question is not which procedure wins. The real question is, what is the best treatment for this particular patient sitting in front of me today? And the answer to that is almost never as simple as picking a side in a debate. So I want to step back from the battlefield entirely and offer a different perspective, one that I believe is more useful, more honest, and more patient-centered. Let me start with why this matters so much. Carotid artery disease is responsible for 15 to 20% of all ischemic strokes. Once a patient has had a transient ischemic attack or a minor stroke from carotid disease, their risk of a further, potentially devastating event is frighteningly high, up to 25% within the first 2 weeks alone. This is what we call the hot carotid state. It demands urgent, thoughtful, decisive action, not philosophical arguments about which procedure deserves to win a conference session. Now, the guidelines that govern how we manage these patients are built almost entirely on 3 landmark, randomized controlled trials: NASCET, ECST, and CREST. Genuinely important studies. I do not diminish them. But here is the uncomfortable truth. They were conducted between 20 and 30 years ago. The medical therapy available in those trials was a fraction of what we can offer today. The surgical techniques have since been considerably refined, and the endovascular technology has been completely transformed. Yet we continue applying those old results as if nothing has changed, as if we are still practicing in 1991. That is the problem I want to address. Because what the endless CEA versus CAS debate ignores is that there are not 2 options, there are 3. And all 3 have advanced dramatically in ways the original trials could not have anticipated. The first is optimal medical therapy, high-intensity statins, PCSK9 inhibitors, antiplatelet agents, aggressive blood pressure, and glycemic control. This is not the aspirin-only era of those original trials. Modern medical therapy is a genuine revolution in pharmacological stroke prevention, and it forms the non-negotiable foundation of care for every patient with carotid disease, regardless of what else we decide to do. The second is carotid endarterectomy, the surgical gold standard, now further refined with eversion techniques, patch angioplasty, intraoperative neuromonitoring, and early timing protocols that have made it safer and more durable than ever before. The third is carotid artery stenting, including the newer transcarotid approach with dynamic flow reversal, known as TCAR, and next-generation mesh-covered stents, which have transformed what was once a risky procedure into a safe, effective, and sometimes superior option for carefully selected patients. These 3 are not competitors, they are complementary. Each has a distinct role. Each has patients for whom it is clearly the right answer, and denying any one of them because it lost a debate at a conference based on trial data that is now 30 years old is not evidence-based medicine. It is doing our patients a disservice. In the next episodes, I will elaborate on each of these 3 options in detail, the evidence behind them, the remarkable advances that have been made, the patients who benefit most from each, and a practical framework for choosing between them in the clinic. Because the goal is not to declare a winner, the goal is to give every patient the treatment that is right for them, in experienced hands, local availability, and at the right time. Thank you so much for listening to this episode of Stroke News. If you found this useful, please do subscribe so you never miss an episode. And if you know a colleague who would benefit from this conversation, share it with them. We will see you in the next one.